We will be lifting off in 30 seconds. And we're going to be talking about higher order cortical syndromes affecting vision. All right, great. This is one of my favorite topics. Why? These are the patients where they come to you, not me, but you, and they say, Doc, something's wrong with my vision. And you say, well, I can fix that. I'm an ophthalmologist. And you look in the back of their eyes, and it's normal. The optic nerve's normal. And you look at the macula, it's normal. You say, that's okay. I'm going to get an OCT, and I'm going to find something. And you get your OCT, it's normal. So that's okay. I'm going to look at your eye movements. Look at my eye movements. Normal. And you say, well, what's actually wrong with your vision? And that's when you have to do something very special. Listen to the patient. I'll tell you, as ophthalmologists, we love to look in the back of the eye. I love to look in the back of the eye. And we love our gadgets. But in the end of the day, there is nothing more important when you have a tough case than listening to what the patient has to say. So in the next lecture, a lot of what we will do is listen to patients. What we've done here is for every higher cortical syndrome, we have the description in the patient's own words. So I want to start by thanking my patients for being generous with their time and their spirit to describe what they went through. I also want to thank a great neuro-ophthalmologist named Sashank Prasad from the Brigham and Women's. He and I give this lecture and a course in the American Academy of Neurology every year. We just gave it last week. And some of these cases are his, and half of them are mine, half are his. So I thank him for helping to develop this with me. I have no relevant financial conflicts. Everybody here knows this picture, right? We all know someone has vision loss. We know that you can have, geographic field loss from retina, secocentral scotoma, altitudinal. What optic nerve problem causes altitudinal? Yeah, ischemic optic neuropathy. Bitemporal from optic chiasm. Homonymous hemianopia from the optic tract. This is a good one. This is sectorinopia. When the lateral geniculate nucleus in the thalamus has a stroke to the anterior choroidal arteries, they feed the medial and lateral side of the LGN, and you get this sector. If it's the posterior choroidal artery, it affects the central sector, and you get the mirror image of this. That's a cool one. Meyer's loop in the temporal lobe gives you a pie in the sky, superior quadrantenopia, optic radiations inferior, and of course, the occipital cortex, homonymous hemianopia with macular sparing. Okay, but what happens after the occipital cortex? What is that black box of visual processing that happens afterwards? Well, Ungerleider and Mishkin in 1982 came up with this kind of simple but helpful way of thinking about how vision is processed after it leaves the occipital cortex. And what they explained was that one stream of information heads ventrally into the temporal lobe. And that's called the what pathway, because that processing is about what I am seeing. I'm looking at a bottle of seltzer. That's happening in my temporal lobe right now. The second pathway goes more dorsally to the parietal lobe, and it's called the where pathway. I am looking at this very complicated scene. There's paintings to the right. There's a wonderful ophthalmologist in front of me. There's a ceiling above. All of this put together in a scene, and that requires the where pathway. Or I'm moving my hand. That requires acknowledgement of movement. That's the where pathway. So let's now look at this in more detail. This is the brain, a little cartoon. This is V1, Brodmann area 17, the occipital cortex, otherwise known as the striate cortex, because it has a stripe on pathology. What are we really processing in the occipital cortex? Basically, border zones between black and white. And we also can tell, is it on the right side of the vision or the left side? That's really about it. If you took away the rest of the brain, that's all about the occipital cortex is telling you. It's got all the information, but it's not processing it yet. So now let's move along the ventral stream. As we get to V2, V is for ventral, we start to understand color a little bit, and we start to understand orientation. The water bottle is right side up, oh, this is kind of heavy, and not, upside down. That's happening in V2. And foreground, background. The podium is in front of the ophthalmologists, not behind, that kind of thing. V3 doesn't do much. And then we get to V4. Now, V4 is really interesting. Here, we have all of that, but color becomes really important in V4. And we'll see later, this is known as the color center for human beings. And we start to now understand shapes. So I want to understand this kind of weird trapezoid, whatever it is. That is V4, putting that all together. And then V5, or not V5, the inferotemporal region, which has no number. What are we understanding there? Anyone know? Even more specific than a shape. Yeah, recognizing. What's the most important image or object that we need to be able to recognize from the time that we're a baby? Face, right? We need to know who's mom and who's dad and who is a vicious tiger trying to kill us. We got to be able to differentiate those, so faces are important, and that's why this is faces. What's that? Or you could have prosopagnosia if that's messed up, so we're going to see that. Dorsal stream. It goes to V2D, V3D, and then it makes a pit stop in an area that's between the temporal lobe and the parietal lobe called the mesial temporal area, MT, or V5. There, we have information about the movement of objects, but also about the movement of our own eyes. Because if we don't take into account our own eye movements, we can't have the relative understanding of how something else is moving. It's like when you're on a train, you have to take into account your own movement. And V6, the dorsal media area, takes into account your own movement and also the movement of your hand. Because the second most important thing when you're a baby, in addition to recognizing mommy's face, is reaching for stuff. If you can't reach for that bottle or reach for that baby food, you're in trouble survival-wise. So reaching is very important. We're going to talk about that too. And then it all gets processed in the posterior parietal cortex. That's the seat of understanding where things are and how things are moving. Good. From now on, we are just going to look at problems with these two pathways, and you're going to hear it described by our patients. Problems with the what pathway? I thought I'd give you a nice, very complicated object to look at. Okay, here we go. A 42-year-old woman complains that she sees a cartoon character wherever she looks. She's not aware of any vision loss. Let's see what happens here. Very nice young woman. Whoops, let's go back. Can we, did we lose our AV? Let's see if I can get this going. No? Let's see. Okay, hold on. I can do it. Oh, here we go. Sorry. We're going to need your help clicking some of these videos. I don't know why, but let's click on this one. Thank you so much. She said she's know Dora the Explorer? If you have kids or nephews and nieces, Dora the Explorer, and she's got the little backpack. So she is seeing Dora the Explorer everywhere. And she came to me with this complaint. That was her chief complaint. It was really weird because on the little form, what my technician writes, her chief complaint, seeing Dora the Explorer. It's like, okay, stop watching television. No, but she's seeing her everywhere. So what is this? This is a visual. Yeah, it's a hallucination. But she has no knowledge of vision loss, but here are visual fields. Can anyone tell me what the visual fields show? Yeah. Where does this localize to? Yeah. She probably has optic chiasm plus optic nerve. And what do we call the scotoma? Well, yeah, you can call it a junctional scotoma because it's at the junction of the chiasm and the optic nerve. So you're affecting both. So then we go ahead and we get an OCT and fundoscopy. What do the nerves look like? Yeah, they're pale, they're cupped. This is atrophy, and you see it on the OCT. So something's going on. What do you want now? MRI. Excellent. It's either MRI, aspirin, or give me a salary raise. All right, those are the three things neuro-ophthalmologists want. And here we go. So what do we have here? Yes, tumor. What kind of tumor is that? It's probably a meningioma because you can see a dural tail here. probably here, but it's a meningioma. So she probably has had this meningioma growing for 20, 30 years, slowly causing vision loss. So when you have vision loss, you can get visual hallucinations. What's that called? Anyone know? Charles Bonnet syndrome, exactly, Charles Bonnet syndrome. He was a Swiss naturalist. He was not an ophthalmologist, but his grandfather had cataracts. And he described in a very famous paper these illusions. An illusion, actually, it's really called hallucinosis. Hallucinosis means the patient is aware that it's not real. So usually with Charles Bonnet, they're aware. Like my patient knew that Dora was not actually visiting her. And these hallucinations occur in 20% of your patients with severe vision loss over the age of 60. But how often do you hear about Charles Bonnet? A lot? Yeah. 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 Do you ask them about it? Do you say like, yeah, see, if you don't ask them about it, they won't tell you because they're embarrassed. Oh my God, the doctor's going to think I'm crazy. But if you ask them, do you have hallucinations? They'll say, yeah, oh my God, thank you for asking. I was so worried about it. And then you can really help them. You help them by saying, look, this is normal. You have macular degeneration or vision loss for whatever reason. Your occipital cortex is being released. There's nothing coming out of the occipital, nothing coming into the occipital cortex because of macular degeneration or whatever. So the occipital cortex is going to try to replace it with its own visual stimuli. And that's called release hallucinations or Charles Bonnet. Here is Charles Bonnet's original paper. Anyone read French? Well, we translated it. I could tell you on the subject a very singular case. I suffice to say that it was a respectable man with full health, candor, judgment, and memory. I think he wanted to be nice to his grandfather, who in plain day and irrespective of any stimuli will perceive before him figures of men, women, birds, cars, and buildings. And this was his own grandfather. And so generally with Charles Bonnet, the hallucinations will be small. They're called Lilliputian, like Lilliput. They're small and they're friendly, usually. That's why I love this case, because what is smaller and friendlier than Dora the Explorer? It's like the perfect case. And generally, these are various diseases that can cause it. The top one, just like you pointed out, macular degeneration. But all of these things can do it. And there are a lot of treatments. Do you ever treat your patients? What do? You reassure them, right? Reassurance is the number one treatment. But you can try an SSRI, like Paxil or something, or you can try a neuroleptic, like Zyprexa, olanzapine, and that will help some patients if it's really bad. You can actually even have Charles Bonnet in a hemionopic field. I had one patient where on the left she could see, but in her hemionopic field she was seeing dragons. And so sometimes you get partial hemionopic Charles Bonnet syndrome. So Charles Bonnet, going back to our map, is when you have a problem with your retinas or optic nerves or eyes or anywhere in the pathway and your occipital cortex responds, the what pathway tries to fill in the what when there is no what. Okay? Visual hallucinations are not just from that, but can also be caused by dementia with Lewy bodies. Anyone ever hear of that? It's like a degenerative disease. Robin Williams, the comedian, had it, unfortunately, and many of your patients will have that. They have visual hallucinations because of occipital degeneration. Peduncular hallucinosis, when you have a stroke in the midbrain, a small one that affects areas in the midbrain that probably inhibit the dream state. We all have hallucinations every night, right? I had some last night, while I was dreaming, all right? And the midbrain, while we're awake, is inhibiting the dream state. But if you get a stroke in just the right network, the dream state comes in the waking hours, and that's peduncular hallucinosis. And other things. Anyone ever see Creutzfeldt-Jakob disease? Prion disease? Very terrible disease from prions. The Heidenhain variant can have visual hallucinations. Let's go to our next case. So if we can click on the video.
How is your vision?
My vision.
What am I holding now?
It's okay.
It's okay? Yeah, you see it?
Do you see it?
Yes.
Lentes.
Okay.
in Spanish, right? So he now knows what it is. This is a man who, when you ask him, he says, my vision's fine. Yeah, I can see you. He actually described my friend Dr. Prasad as having, I don't know, hair color that was not accurate, but he's coming up with a whole thing. So what do we call this syndrome? You know what? It's exactly. This is an anosagnosia. Anosagnosia means you don't know what you don't know. You don't know what you're missing. And that happens with acute vision loss sometimes, especially if it's bilateral cortical vision loss. Okay, and we see here, this guy, this is diffusion weighted. What do you see here, guys? He has atrial fibrillation, emboli to both occipital cortices. Here's the ADC map showing the two strokes. Infarction, yeah, bilateral, very sad. Okay, but this is called Anton syndrome. Anton described how people with bilateral cortical disease and cortical vision loss for a few months may have this anosagnosia, and they'll confabulate their visual environment. They don't know that they can't see. Here's the original description of Ursula Mers, a 56-year-old needlewoman, was treated in Graz Hospital. Graz, where's Graz? It's like over there. It's really close, here in Austria. Okay? And her condition was characterized by complete blindness, but her pupils and fundi were normal. And even a sudden approach, no reaction, totally blind, stared off into space. But it was striking. The patient didn't take any notice of her complete loss of vision. The patient, who otherwise complained a lot, was almost unaffected by the vision. I love how in this case report, Anton feels the need to complain about the patient's complaining, but doesn't complain of the vision loss. And then, back then, they didn't have MRI. What did you have to do? If you were a neurologist and you wanted to figure out what was going on, you call the ophthalmologist. I like it. But this is the 1800s, so in order to know what's happening in the brain, you wait for them to die. They waited around. Patient had probably another stroke, and they died. Okay, and what did they find? Examination of the brain showed only necrosis in the occipital cortices. And Anton was very smart. He says, the condition may represent a breakdown of the functional relationships between cortical areas, like an association problem. In the absence of occipital signal, another part of the brain, which is aware of whether you have vision or not, in the absence of input, may be too confused to even know whether you have vision or not. What part of your brain do you think makes the decision consciously about whether you can see or not? Yeah. What's that? Oh, good. Well, the thalamus maybe. The thalamus kind of the input, the sensory relay. But what part of the brain makes decisions? Cortex. Which part of the cortex? Frontal, right? Exactly. So this is probably the frontal cortex not getting the memo that you're blind. And for a few weeks, it can't make up its mind. So here, Anton syndrome is occipital cortical disease and probably frontal lobe not being able to decide whether you have it or not. Let's look at this one, cerebral hemiachromatopsia. This was an 81-year-old woman. She can't see to the right and up. So she's got a right superior quadrantenopia. Let's see what happens when we check color vision in the intact inferior area. When you hear about color vision loss, you usually think about it in one eye, right? Usually, and what do you think about? Color vision loss in your right eye, what does the patient have? Optic neuritis or macular degeneration, something macular or optic nerve. But here, I'm not talking about color vision loss in one eye. I'm talking about it in one visual field. Very rare. Let's see what happens. So if we can click on this one.
Tell me when you're aware that I have a finger, okay?
It's okay on the left side.
Yep.
Okay, left. Okay, now we're in the right superior area, quadrantenopia. She can't see my finger in the right side.
Okay. So that's the inferior superior quadrantenopsia, but
inferior is spared.
Okay, now tell me the color of the cap.
That's left side.
Here.
Lavender, good.
Lavender, I agree.
Pink.
Okay.
She finally got it. Yeah, okay, left side's good.
It's stage fright, I know. Okay. And here, look straight at, and what color now?
That's inferior. It's hard to tell, but that's inferior.
Can you tell the color?
She can't tell the color.
Okay.
She can see
Open
it.
your eyes nice and wide. Okay. Tell me when you see the bottle being moved in front of you there. You see that bottle? Yep. Can you tell the color?
No.
No. One
She
more.
can
one
see the
more for
bottle,
you.
but she can't tell the color.
Tell me when you're aware that there's a bottle here.
Okay.
Can you tell the color?
So she has loss of color vision down here in this spared area. These are visual fields. So the inferior quadrant is just grayed out from color. So what is this? Here's her infarct, left occipital cortex, okay, due to an embolus. And this is called central hemiachromatopsia. This was described by Very many years ago, 1888. And in this paper, Absolute Right Hemiachromatopsia, he described Mrs. R. And on examining the visual field for color using little colored paper instead of bottle caps, found that color visual was abolished in half of the visual field in both eyes, like a achromatopsia homonymous, but normal color on the other side. And the patient would say everything was gray. So she came in complaining that she lost color vision in that side. Yeah. She noticed something was wrong. She basically said, I have black and white vision on one side, suddenly. Again, she passed away some years later. And when she did, he found that there was necrosis, this lesion below the ventricle in the third occipital gyrus, what we would call V4 now, more or less destroying the lingual and fusiform gyri, which are there around the occipital cortex in visual association areas. And Very says the center of color sense appears to be inferior to the occipital cortex, probably in the lingual and fusiform gyri. So he comes up with this idea there's a color area. Well, this was heresy. The idea back then in the 1800s by Willebrand and Henschen and Holmes was that no. In the occipital cortex, color processing occurs and it leaves the occipital cortex. So their idea was you could destroy the rest of the areas outside of the occipital cortex and you'd still have color vision. But Very says no. This information comes out of the occipital cortex from V1 upper and V1 lower, and it goes to a special color area so that if you kept your occipital cortex but lesioned just the color center, you would see in black and white. Very interesting idea. And they laughed at him. They said, Very, you're a fool. And he was a very disappointed man. Until 100 years later, when Zecchi decided to check Very's theory and did single unit recordings on neurons in V4 and found a population of cells that only responded to color. If you showed black and white vision, the cells were quiet. If you showed color, action potential. And each population of cells had a different frequency map. So some of them were more red, some of them were more green, some of them were more blue. So he found it was like the retina. You had these color-sensitive cells in V4. And then Lueck and colleagues showed with PET scan that this area lit up, but only from colored stimuli. So now we know that Very was right, and we have this colored center. Here are my kids. This is a few years ago, but this is Max. Max, he's now driving, very scary. Here's Benjamin, he plays guitar. And Sophia is a gymnastics kid, and she also is very excellent at never listening to her parents. She's very good at that. But they're wonderful, and this is the Long Island Sound in New York, near where we live. But let's say you're looking at a picture of my kids, and generally, if you had a lesion that affected V4, it should be moved over here to V4, the color center only, then you would get just black and white on half the world. Sophia is now in black and white, just like Very's case. But in most cases, this is what you'll see clinically, everyone. You'll see the lesions a little bit bigger, and it affects the inferior occipital cortex, so you get a superior quadrantenopsia with it. Okay, and that's what my case had. So hemiachromatopsia with superior quadrantenopsia. And this is the kind of thing, by the way, that unless you look for it, you will not find it. You have to look for it. Next case. Quote, I couldn't make out objects. A 23-year-old woman with blurred vision. She had overdosed on heroin, had hypoxic arrest, and resuscitated in the field. Then she developed headaches and noticed her vision was fragmented. She couldn't recognize objects. But in the ER, they thought she was faking it. Why? She was walking around. She wouldn't bump into things. Let's say she walked up here, walk out of the way. So she could see. She wasn't blind. When Dr. Prasad tried to check her vision with a card, couldn't do it. She had basically counting fingers vision. Check color plates, couldn't do it. Asked her to identify a pen, a watch, couldn't do it. Shapes, couldn't describe them. And yet, she could see. She wasn't bumping into things. Okay? And in fact, the suspicion was that her vision was 20/20. Let's hear her discussion. This is called apperceptive agnosia. We can click on
Like I could tell that there was objects, like if there was an object in front of me, just because I could see like a vision of it, but I couldn't tell what it was. Like I couldn't make out anything.
Where they're 20/20, and yet they cannot describe anything in front of them. They can't even tell you that this is a thumb. Okay? Very interesting. And she says it so eloquently. Okay? So because she couldn't make out objects, she can't make out letters. Therefore, you can't test her visual acuity. So instead, what do we use? The teller cards. Anyone ever use a teller card? It's for kids, right? It's got a little hole, and you're looking at the baby or the little child. And on one side of the teller card are stripes, black and white. On the other side is gray. And you look, if the kid looks at the stripes more than the gray, they can see the stripes. And then you pull another card, you get thinner stripes and thinner stripes. And each stripe is a finer and finer set of stripes matching a certain visual acuity. So we checked it in her. Do you know what her vision was? 20/20. She could see fine. She just can't identify letters. So we have her copy some objects. At first she's okay, but when we get more complicated, she falls apart. This thing she copies like that. Here, all over the place. Something is going on where she cannot put together what objects are. We get an MRI. At first we think it's normal. Does anyone see anything abnormal here? Good. Look at that. She's got basically strokes of her cortical ribbon in her occipital cortex. Not the whole occipital cortex so that she's blind, but her gray matter has been really affected by the hypoxia. Okay, so she's got occipital cortical disease. And this is what we call visual agnosia. This was described by Lissauer, okay, way back in 1890. The patient Gottlieb L., an 80-year-old salesman, he frequently would mistake articles of clothing. He would mistake his jacket for his trousers. He's trying to put his trousers on his hands. And when eating, he'd mix up the fork with the spoon. Anyone ever read the Oliver Sacks book, The Man Who Mistook His Wife for a Hat? It's a whole book or short story about someone with visual agnosia, okay, mistaking things. He was quite incapable of recognizing the most common objects, but if he touched something or heard it, he could recognize it. Furthermore, he could see. It was clear from the way he was able to look and handle objects. And he tested the acuity with small dots, and it was 20/20. And he said, I will concern myself in my paper with this thing I'll call visual agnosia. And I'll divide it into two stages. The first would be apperceptive agnosia, meaning the patient cannot even perceive what they are looking at. They can see it, they're not going to bump into it, but they can't put together all the features of it to say, this is a screen podium, okay? They can't put it together. The second stage is where you know what it is, but then you have to come up with a name. So I might look at the water bottle. The first stage is putting it all together to know that that's something that contains water, and you pour it and all that. But the second stage is to get the name for it, water bottle. And that's called associative knowledge, where you have to associate what it is with a word. Depending on where the problem is, you can get either one. Which one does she have, do you think? She's got the first one. She really profound. It's not that she just can't come up with the name. She can't even really understand what it is. And so you can have both. It's generally accepted visual agnosia is caused by extensive damage to the occipital cortex. Now watch this here. If we can play the video. Here's her copy, but good. I just wanted to show you that. When she had to pick up the paper, did you see if she was able to grab it? It's like she had no problem knowing where the paper was, but if you showed her paper and said, what is this? She couldn't tell you. So here's the two steps. Basic processing, that's apperception. Then associate it with a word, that's association. You can have agnosia from either one of these. Okay, so where is this located? Occipital cortex. And this is a good one because you will see this. I've seen this like once a month, but they don't come in telling you they have it. They just say, everything is off. I can't tell you what anything is. But the optho exam is normal, and you've got to figure out that you're looking at apperceptive agnosia. Let's move on to this gentleman who came in saying he had a major problem. We'll hear what.
It started, I will say, by recognizing features. I see a nose and eyes, but everybody's nose and eyes and mouth look the same as everybody else's. Mm-hmm. So the features are there, but to discern one person from another, not so easy. And if everybody's wearing the same wardrobe, it really becomes a problem.
So look at this. He can't recognize faces. And if people are wearing the same clothing, like if we're all wearing suits, he would not be able to tell one person from another. And this has been happening for a few years for this poor guy. He even told me when he goes to a party with his wife, they came up with a whole system whereby she would wear a dress with a flower on it so he could find her and say, that's my wife, because the dress is a flower. What do we call this? You mentioned it earlier. What is this called? Yeah, prosopagnosia. Can't recognize faces.
Got it. What about famous people? Are you able to recognize famous people as far as you can tell?
I thought so, but then we were looking at a picture of Hillary Clinton, and she said, "Who is that?" And I said, that's some blonde woman.
Yeah,
So
he just recognized Hillary Clinton as a
sometimes-
woman with
sometimes.
blonde hair. And this was a time from like 8 years ago where every moment on the news was Hillary Clinton, right? At least in the United States. Or she ran for president against Trump. And so even a very famous person who's in the news all the time, he couldn't recognize. So very profound prosopagnosia. And so prosopagnosia was actually described before Bo Dammer in 1947, but Bo Dammer really had a very good description. And actually, can we go back one slide? I think I skipped ahead. Yeah, okay. Case 1, a 24-year-old, bullet wound. Okay, this is World War II. The left inferior occipital temporal cortex. Blind, but then vision returned. And afterwards, the patient said, I saw well, almost as well as before the injury, but faces, I saw them as badly as ever. Apart from the eyes, everything is blurred. The faces seem pressed flat. There's no three-dimensionality to it. I don't see expressions. When I look for that which is special about the face, I don't find anything. And so then, Bo Dammer performs an experiment that you would not get away with now. In the experiment, they bring in the wife of the patient and several nurses, and they dress the wife in a nurse's uniform, and they line them all up, and they're about roughly the same height, and the patient could not pick out his wife for 5 minutes. So you couldn't get this experiment past the IRB nowadays. But now it proves that he can't even recognize his wife amongst all the other nurses. So prosopagnosia, he says, can be defined as the selective disruption of faces. Even your own face, you can't recognize in it. It's very disturbing. And how do we know more about this? Now, fast forward to Nancy Canwisher's studies with fMRI. Okay, this is now the 80s. And here we show someone faces, and you can see that this thing lights up. Every time they look at a face, it lights up on fMRI. But then when they show them an object, it doesn't light up as much. Face, object, face, object. And that is the facial area. Remember we were showing it earlier, the anterior temporal lobe, okay? Inferior anterior temporal lobe. Show objects, you get more of a bilateral response, and it's more posteriorly. Object, face, object, face. So there's an object area, more posterior, and a facial area that tends to be on the right side in the fusiform gyrus. Here we do intact faces to make sure it's not just a function of how much ink is in the picture. She does scrambled pictures, and we get a really powerful signal in the facial area. To make sure it's not just any kind of icon, we do faces versus houses. Lights up really well, okay? And to show you how powerful the facial area is, I show you this painting by Giuseppe Arcimboldo. What do you see? Vegetables. What do you see now? You see a face, right? Arcimboldo, his paintings all have hidden faces if you turn it upside down. And everybody loved to buy Arcimboldo in Italy back then. So you can see that when it's right side up, if the features are not in the right order, if they're not in the exact facial area, you don't even see it. But the minute that you actually have them, eye, nose, and mouth, we are trained to pick it up. That's how powerful the area is. Here's another illusion based on this. This is, anyone know who this is? Wow, you guys are good. Margaret Thatcher. Anyone watch The Crown? Yeah, it's Margaret Thatcher, okay? So, Prime Minister of England from the 1980s. And it looks like an okay picture when it's upside down, but watch this. When it's right side up, it's like, whoa, there's something really messed up about this picture. And that's because when it's upside down and it's not in the expected orientation of a face, We're not using our facial recognition area. We're using our object area. We know it's a face, but we're kind of saying eyes, nose, mouth, face. But we're not actually recognizing it as a face. Once it's right side up, we're looking for a normal face, and when we don't see it, wow, it's messed up. So object processing for the upside down, but once it's right side up, we're using our facial processing area. Here's more fMRI work. Here is a control object area and facial area in the temporal lobe. Somebody with prosopagnosia, when they are shown an object, the object area, it lights up, but face, nothing lights up because of a stroke. But this person who has acquired prosopagnosia, object area for objects, and what lights up for faces? The object area. Again, they're using their object area to understand faces. So they're not going to understand faces really well because they're using their object area instead. Here's somebody who was born with prosopagnosia. Anyone here have prosopagnosia? Some people are born with it a little bit. Developmental, what's that? What is it? We'll talk after. So here, developmental prosopagnosia, and look what's happening there. Their facial area is quite developed, but it's not really a facial area. It lights up for faces and objects. So prosopagnosia is a problem in the anterior temporal lobe, and very serious. Let's talk about the Riddoch phenomenon. A 15-year-old girl, dense right visual field loss, but she's able to see motion, and she's got a left occipital cortical enhancement. Here's the necrosis. Okay? So here, she says, I can see when things are moving, I can see them coming, like a car or whatever. But when I do this, how many fingers? Nothing. But when I move, she goes, yeah, I see it right now. This is called the statico-kinetic dissociation. You'll see this in your patients where they can see movement, but not simple objects. It's a kind of blind sight. Riddoch described this in a patient from World War I. Lieutenant Colonel T was wounded on April 6, 1916, by a bullet in the right occipital region while advancing into action with his men. He did not fall, and though dazed, he soldiered on. He noticed nothing wrong with his vision. But when he was transferred to Bombay in May, he noticed he couldn't see anything on the left. He used to miss pieces of meat on the left side of the plate. But if objects were moved, it was okay. So because moving objects are what you see in war, because you're running and things are, he didn't notice the problem. It wasn't until he started eating and going back to the base he noticed it. Okay, and they find that he's got blindness. Okay, to anything that is not moving, but things that are moving he sees fine. And this is described as the Riddoch syndrome. Okay, and the bullet was in the right lobe in the occipital pole. So now, fast forward to some fMRI work. Here was somebody described by these doctors, Bridge and colleagues, where they have Riddoch phenomenon, and when they're seen moving images, there's no activity in V1. But V5, remember V5? That's that area that sees movement, is lighting up. How is V5 getting the information if V1 is gone? What do you think? How does the movement area light up if the occipital cortex is not lighting up? Where is it getting the information from? Well, we don't know, but there must be some other projection, cortical projection to V5. And I'll skip this slide, but it must be probably from the superior colliculus. So in Riddoch phenomenon, probably what we have is occipital cortex is gone, but there's some other pathway from the eyes, from the optic nerves, right directly to MTV5 to pick up the motion. And I think it's probably through the superior colliculus, but that's a theory. Okay, so that's Riddoch phenomenon. Look at that. By the way, why was this described in England? Every other patient that I've been, showing you from history was in Austria, France, Germany, where a lot of the big neurologists were. Suddenly, World War I, we have somebody described in England. Well, it has something to do with the helmets. Here's the German helmet in World War I, and you can see it covers the occipital cortex. Not so the British helmet. So a lot of occipital disease was described in the soldiers because bullets could easily get into the occipital cortex. So that's just a little historical fact of why. So bad for the British troops, good for the British neurologists. Okay, let's look at this. I have trouble reading. A 41-year-old woman presented to neuro-ophthalmology clinic with chief complaint of trouble reading. Right homonymous hemianopia. But she has alexia. Very good. Alexia. Can't read. Let's watch her writing. I asked her to write. Yeah, she writes, let's walk to the park, president, Congress, let's talk about politics. She was very interested in politics. Okay, she could write, no problem, but I brought her back 5 minutes later. Now let's click on this one. I say, can you read your own writing? She just wrote this herself. She can't read it. So she has alexia without, what does she not have? Agraphia, right? Alexia without agraphia. She can write, but she can't read. She can't even read what she wrote. It's crazy. How does that happen, right? So this is her MRI. And you can see there's something with a tumor and infiltrating edema or tumor in the left occipital cortex, which is what you need for alexia without agraphia. But what else is being involved, everybody? What's this? Connecting the left to right side. It's like the crosstown bus between the left and the right brain. The corpus callosum, specifically the splenium, which connects the two occipital cortices. Okay? So you have splenium plus left occipital cortex is what gives you alexia without agraphia. Why? Well, let's look. That is the language network, Wernicke's area over there. Okay? So we'll get back to that. But here is the description of alexia without agraphia by Desjardins. Okay? And Desjardins described that there was a loss in his patient there was necrosis, stroke in the occipital cortex, but look here, what do you see here? Stroke in the splenium too. So if you have that combination, you lose the ability to read, but you still have the ability to write. And he says the spoken language is very correct. Appropriate terms, there's no paraphasias, no problems, but reading what he has written is absolutely impossible. And he calls it absolute word blindness. And the patient says to him, I still know how to write letters. Here they are. Why can't I read them? And then he goes on, and the patient writes this whole paragraph in French, but then he can't read it. It's actually a cool paragraph. He writes, I went to Paris to the Salpêtrière, which is the Neurology Institute, and I'm examined by Charcot, very famous neurologist, for a very long time. So it's Charcot, the famous neurologist, makes a cameo in Desjardins' paper. And here's the right homonymous hemianopia. Okay, so here's our patient. There's the language area. The left occipital cortex has disease, so there's a right homonymous hemianopia. But the right occipital cortex is okay. They don't have any problems looking to the left. So why can't they read words with their right occipital cortex, everyone? Why can't they use the spared occipital cortex to read? Yeah, they can't get that information across the crosstown bus over to the language area. So they can see, but they can't get it over to the language. But writing is okay. Okay? So here, there's the intact area, but it can't get across the splenium to the language side of the brain. But for writing, I think I have this in here, Broca's area is intact, which is your output of writing. All you need to write is Broca's area, which is in the frontal lobe, to connect to your frontal cortex, motor cortex, to write. So that's intact. And so you have alexia without agraphia. You've got some fMRI work here where they showed them words versus scrambled words. Now this is another way to get alexia without agraphia, with one lesion. Some people will just have one lesion, very rare. Okay, but if you show people words versus scrambled words, this area lights up. Okay, and that area in the left occipital temporal sulcus, connecting your temporal lobe to your occipital lobe, if you get a lesion right there, that's the pure word form area, okay, and you can get alexia without agraphia, without needing the splenium. Okay, and here we did lesion overlap, Dahan and Cohen, from 6 cases of alexia without agraphia. All of them had this area here involved. So that one lesion right there can give it to you. Occipital temporal sulcus. Meanwhile, your angular gyrus can give you agraphia as part of the Gertzmann syndrome. You need that area for writing. All right, and I'm going to skip this. Okay. Now we're going to end with one last case, everybody, because we're almost out of time. I'm sorry, we'll go 5 more minutes, I promise, and we'll finish up. This is the wear pathway, because we got to do the wear pathway. Okay, this was a woman who had trouble lighting the Friday night Sabbath candles. So let's.
All right, so I went to light candles Friday night, this week and last week. This started last week, and I wasn't getting the fire. I was getting everything but I cannot hit that wick.
Was it because you couldn't see the wick?
No, I saw the wick. I took the match. I went to the wick, and I wasn't catching it because I was maybe about a half an inch away from it. So I saw it, but it never connected.
And
So dangerous, right? She's trying to reach the candle with the match, and she's a half an inch away. Tries again, half an inch away. She can't get the match to the candle to light it. And I say, well, can you see the candle? Yeah, I see it's a candle. I ask her, can you name, my thumb? Yeah, it's a thumb. She names the candle. She can see everything. There's no apperceptive agnosia. There's no blindness, but she can't move her hand to the proper place. So I check to see maybe she's got a cerebellar problem, but there's no dysmetria. And then I say, can you touch my finger? And this is what she does. Try again. Everything but. So then I say, can you touch your own nose? She goes, sure. No problem. What is this called? You're close. What is this called? Yes, optic ataxia. This is optic ataxia. Okay, it's a kind of ataxia where they can't get their hand to the right place, but it's not cerebellar. It's because of a visual problem with the wear pathway, optic ataxia. And optic ataxia, you can test them by having them go from one object back to another. Okay, and you always have them touch their nose. Why? With cerebellar ataxia, they have bad coordination, so they can't even touch their own nose. With optic ataxia, the nose is fine. Why? What do I need to touch my own nose? Proprioception. And proprioception is fine, as long as it's not visually guided. Here's another patient with the same kind of syndrome. She also had optic ataxia, but I asked her to see, no, go back. I asked her to look at a certain shape and tell me what she saw. And here's what she saw. Good. What do you see there besides the A's? There's a big H. I even said, ma'am, zoom out, and what do you see? Couldn't see it. She couldn't see the forest for the trees, right? She's seeing the trees, but not the forest. This is called simultagnosia. You can't simultaneously put all the features of the world together. A problem with the wear pathway, right? Because the wear pathway in the parietal lobe is taking all the objects that you can see, and it's connecting them with your GPS of where everything is located to form a map of the visual world, okay? So simultagnosia. So you can do the Navon figure, that H made of A's, or anyone ever see this? This is a picture from the NIH stroke scale. It's kind of a sexist picture because it's like the mom is in the kitchen and all that stuff, but we still use it. And you ask them, please describe the picture. And somebody who does not have simultagnosia will say it's a kitchen with a lot of bad things going on in it, right? There's water overflowing, the kids are about to fall. In fact, I had a patient last week. I said, what do you see here? I knew they didn't have simultagnosia. They just looked at it once and they go, chaos in the kitchen. I knew they must know everything that's going on. But somebody with this syndrome, which is called Berlin's syndrome, which causes simultagnosia, will say this: water, cookies, bench, but they don't put it all together. Okay, they're just looking at one thing at a time. And what causes these? Bilateral parietal occipital cortex junction lesions. Here's the Navon figure again. And you can look for a third thing. You have optic ataxia, simultagnosia, and ocular apraxia. For ocular apraxia, may I examine your eyes for a second? I'll say, okay, look here, look here, look here. Good. She does not have ocular apraxia. But someone with ocular apraxia is going like this. and not really getting to it right. It's just like the optic ataxia, but with the eyes. So here you just have them look at one image to another. And here's the lesion in our patient. Bilateral parieto-occipital cortex, cutting off the connection between the wear pathway and the brain. And here's another one of my other patients I showed you, the one that couldn't read the H. Her MRI was read as normal. Is this MRI normal, everybody? What's wrong with it? Yeah, a lot of atrophy in the parietal lobe. The frontal lobe looks not so bad. So what disease is this? It's probably Alzheimer's disease, but it's a special syndrome we need to know as ophthalmologists where Alzheimer's disease affects the occipital and parietal lobes more. And our patients have visual syndromes like we saw today. This is called posterior cortical atrophy, PCA, which I didn't write in the slide, I'm sorry, PCA, posterior cortical atrophy. It's a syndrome that can be caused by Alzheimer's disease or any degenerative neurological disease, but it comes to ophthalmology first. So now, Berlin syndrome, optic ataxia, ocular motor apraxia, and simultagnosia from bilateral parietal occipital lesions. Berlin described it in a patient whose chief complaint was that when he would go to light his cigar, he would light it in the middle of the cigar. Not good. Very much like my patient with the candles. And you can see here, he says a complex of symptoms where I've examined them for a long time. And he goes on and he shows the patient, okay, this picture, just like our picture, okay? And he shows it to them. He says, other normal individuals are describing the picture really well. They say, oh, this kid threw the rock, broke the window, this kid threw the rock, but this kid's getting in trouble for it, and now he's hiding. But they asked this one with Berlin syndrome, what's going on? The boy is pulled by his hair. Okay, why? He has revealed a secret. Why do you think that? Because he listens. But that's the other boy listening. Yes, that's another boy. Why is the first boy pulled by his hair? I don't know, I never had an interest in this sort of thing. So this guy, he can't put the picture together. Berlin syndrome. Berlin's can be caused by all of these things, like PRES, posterior reversible leukoencephalopathy, Alzheimer's, strokes bilaterally, and PML. Okay? And actually, the problem is in the sulcus between the occipital and parietal lobe, the intraparietal sulcus. If it's more anterior, it causes a problem with grasping. If it's more in the middle, medial, it's more the problems with eye movements, the optic ataxia. And if it's more here, the ocular apraxia. And if it's more posterior, it's the optic ataxia. So you can have partial Berlin syndrome. And I go into the anatomy here, but don't worry about this slide. I'm going to pass by because we're out of time. And Berlin syndrome is the wear pathway. Okay, and I'm going to skip this slide. It's a bonus slide. And I am even going to skip, well, I won't skip this because you mentioned it, palinopsia, I promised. When someone moves their hand or something and you see a trail of after images. And I will just say, look at the word palinopsia for 10 seconds. And now look at the white screen. What do you see? Right? You see palinopsia. You see an after image, a purple instead of the green and light blue instead of the red. So we all have natural palinopsia after images because our retina is hyperpolarizing after the image. That's normal. But people with pathological palinopsia, they look at like a non-lit thing like this, and then they look away and they see it for like a minute. It's very disturbing. And you can have palinopsia as part of this syndrome, which you may be familiar with, where people see little dots everywhere, and they also see after images, and they get photophobia. What is this syndrome? The whole world filled with dots, moving dots. Yeah, and then they have a migraine aura too sometimes. But we call the syndrome where they see the dots everywhere the visual snow syndrome. And you see it, and a lot of patients will come to you complaining of it if you listen for it. And we never really knew what caused it because MRIs are normal. But now fMRIs are showing lingual gyrus hypermetabolism. So we now know there's a problem with the lingual gyrus where it's basically underactive, and it's probably not suppressing the normal noise of visual processing. So we'll end with that visual snow. I won't go into that. I want to thank my colleague, but most importantly, I want to thank my patients for telling their stories, and I want to thank you all for your stories and your questions and your patience.